MCL injuries. In exam, there are questions about MCL injuries, but most of the time the questions are with the associated injuries. So must be knowing what is the mechanism of injury. It is valgus contact, and you must know that when you perform the valgus stress test at 0 degree and at 30 degree, what you are checking? You are checking the MCL isolated at 30 degree of valgus stress test. So what is mostly the treatment? Treatment is hinge knee brace for 6 to 8 weeks. And if there are associated injuries, then delay the ACL reconstruction. When ACL and MCL are combined injuries, there are many questions in which they ask if the patient is having ACL injury associated with MCL injury, how the algorithm proceeds. Not all the MCL injuries they need to be treated operatively. Only the avalian injuries they need to be treated operatively, or grade 3 opening of the MCL they need to be treated operatively. Other than that, grade 1, grade 2 mid substance MCL injuries are treated with hinge knee brace. And if there is associated ACL injury, then it's better to perform ACL reconstruction after MCL. The associated condition that I have talked about, so ACL is most commonly associated with MCL, and 95% of the injuries associated with non-isolated MCL injuries combined ACL MCL, most common multi-ligamentous knee injury. Presence of hemarthrosis is highly suggestive, and it is often associated with high grade MCL injuries. Whenever ACL and MCL they're combined, then there are chances that it can be grade 3 more as compared to grade 2 and 1. The MCL injuries can be associated with meniscal tear, and more association is with the medial meniscus compared to the lateral meniscus. Up to 5% of isolated MCL injuries they are associated with meniscal tears. Most associations are with ACL injuries, but also with the meniscus, and medial meniscus is more involved. There was a question in previous exams about the Pellegrini-Stedi syndrome or Pellegrini-Stedi lesion. I have attached the X-ray. You can see Pellegrini-Stedi lesion. It is the femoral attachment of MCL, calcification at the medial femoral insertion site, and it results from chronic MCL deficiency. So remember this, and this is the grading of the MCL. You must be knowing grade 1, grade 2, and grade 3, and the treatment varies by the grade. Grade 3 mostly needs operative treatment. These are different treatment options: non-operative, NSAIDs, rest, and ice therapy. As I have told, the hinge knee brace, it has role in grade 1. When the patient can return to play in grade 1 injuries after 5 to 7 days. Bracing, NSAIDs, rest and therapy in grade 2, 3. If stable to valgus stress in full extension, it means that MCL is not associated with other ligaments. So the return to play in grade 2 is 2 to 4 weeks, and grade 3 4 to 8 weeks. So this is an important question. It can be tested. Distal MCL injuries, they have less healing potential than proximal injuries. This is an important question, and it can be tested in exam. Distal avalian, proximal avalian. Distal MCL injury, proximal MCL injury. Which injury has better chances to heal? So distal MCL injuries, they have less healing potential than the proximal ones. I have added the questions in this video, and from now onward you will have the questions in every video of this revision session, so you can have a better practice. So I have given the stars to the question as per their difficulty and as per their importance in the exam. So prophylactic hinge knee bracing for contact athletes has shown a trend towards decreased rate of which type of injuries? So prophylactic hinge knee bracing was once thought that it decreases ACL tears, but no, the correct answer is MCL. So it is felt that prophylactic bracing, it decreases the incidence of MCL injuries. Coming on to another question, all of the following, they are true regarding grade 3 MCL tear of the knee except. So you have so many questions like this in CPSP exam or MS exam where there are 5 options, 4 are correct and 1 is incorrect. So don't confuse yourself. Proximal ruptures, they have decreased residual valgus laxity following non-operative tear than distal ruptures. I told you that MCL, distal and proximal healing potential is important to remember. So the statement is correct that they result in greater than 10 mm of valgus opening, grade 3. I have mentioned in the previous slides. They can result in Stenner type lesions. They require operative repair when there is concomitant anterior cruciate ligament tear. Proximal ruptures have better healing potential with non-operative treatment than distal rupture. So in fact, the whole topic of MCL has been revised in this single question. So the answer is they require operative repair when there is concomitant ACL tear. Remember that grade 3 injuries, they indicate complete rupture of MCL with greater than 10 mm opening. Careful evaluation is needed that if the grade 3 opening of the valgus stress test is not in full extension, then it can be operated conservatively. And then so same is written, careful evaluation needed to evaluate for concomitant injuries such as medial meniscus ACL. However, the presence of an ACL tear does not preclude non-operative treatment, but the timing of ACL reconstruction with MCL injuries is somehow changed. You reconstruct ACL after treating MCL conservatively. Grade 1 injuries 3 to 4 weeks, grade 2 4 to 6 weeks, and grade 3 6 to 8 weeks. When the MCL has been healed, then we will go for the ACL reconstruction. So remember that in there can be a number of questions in coming exams regarding combined injuries, MCL with associated injuries, and mostly the question involves the ACL. So the timing is very important, grading is very important, MCL lesion site is important, proximal or the distal one. So coming on to some other one injuries, LCL injuries, they're rarely asked even in the question. The mechanism is respectively the varus contact and the clinical examination. 30° you check the LCL isolated, and at 0° you check it combinedly. If it is isolated ruptured, then we treat it with a brace. If it is combined, then we go for repair or reconstruction. So this LCL, posterolateral complex, it's a bit difficult topic, and sometimes the question is asked in the exam. In fact, almost one question is asked from the PLC section. I want to tell you something about this LCL. The question has been repeatedly asked about the anatomical landmarks of lateral complex, lateral, collateral ligament, and sometimes the lateral complex origin. So you have to memorize where is the origin, where is the insertion, and what is the relationship of LCL, popliteofibular ligament, and biceps femoris. I have added some previously tested questions of this anatomy. I'll discuss it in a while. So you must know that the origin is posterior and proximal to lateral epicondyle. So it is coming posteriorly and proximally to the lateral epicondyle, and posterior and proximal to the insertion of the popliteus. So this can be a question, relationship of LCL and popliteus. LCL is posterior and proximal to insertion of popliteus. You can see over here, this is the popliteus tendon, this is LCL. So it is posterior as well as proximal. Remember this thing. Then popliteus origin is 18.5 mm from LCL origin. It may not be asked, but it's better to have a good grip on memory of good grip on anatomy of lateral complex. Insertion is anterolateral fibular head. So you see anterior and lateral to the fibular head. So most anterior structure on the proximal fibula is LCL. Order of insertion from anterior to posterior. So remember LCL, then comes the popliteofibular ligament, and then comes the biceps femoris. So I have made it quite easy for you That proximal insertion, remember the relationship of popliteus and LCL. Distally, remember the relationship of LCL, popliteofibular ligament, and biceps femoris. So there is a question, 27-year-old soccer player injury right knee after colliding with an opposing player during a game. On physical exam, his Lachman is graded as 1A. He has laxity to varus stress with the knee flexed to 30 degrees. So we are checking the isolated LCL. Dial test of the tibia, it shows increased external rotation at 30 degree, but not at 90 degrees. So 90 degree means PCL. 30 degree means PLC. To the contralateral, which of the following structures are torn? ACL, LCL, ACL and LCL, LC and LPLC, PCL and PLC. See how the questions are being made in the exam. They give you clues, and at some points they confuse you. Although the aim is not to confuse you, the aim is to check how you make differential out of this. See, Lachman is given as grade 1A. So it can be insignificant, but he has given in the option ACL. Laxity to the varus stress test at 30 degree flexion. He could have said at 0 and 30, but the question would be very straightforward then. But he said 30 degree. Now you are thinking that it's only the LCL, but no, he has given you another test. Dial test shows increased external rotation at 30 degree. So now you are thinking that along with LCL there is PLC, but not at 90 degree. So it means PCL is intact. Now what is the answer? The answer is LCL and PLC, posterolateral corner. So go through this explanation as well. Coming on to knee ligamentous injuries, others, posterolateral corner. This picture will show you that if it is negative at 30 degree, then there is the dial test. Then there is no PLC injury. If it is positive at 30 degree, and negative at 90 degree, then only the PLC injury. And if it is positive at 30 and 90, combined PLC PCL injury or medial injury. And I have seen that in repeated 3 attempts of CPSP, they have asked question about the dial test. So remember this thing. There are lateral structures and medial structures of the knee. They are in layers. Sometimes the question has been asked. For example, I have given this common peroneal nerve lies between layer 1 and 2. This question was asked. So layer 1, iliotibial tract and biceps. Layer 2, patellar retinaculum, patellofemoral ligament. And layer 3 is further divided into superficial and deep part. So superficial part includes LCL, tabulofibular ligament, lateral genicular artery, and the deep part are arcuate ligament, coronary ligament, popliteus tendon, capsule, popliteofibular ligament. So the layers must be remembered on the lateral side, and must be known that the common peroneal nerve is between layer 1 and 2. Now there are few tests, clinical tests in CPSP exam, apart from imaging, treatment, pathology, anatomy. The clinical clinical test part is also tested. Yeah, almost in every exam, you have 3 to 4 questions from upper limb and 3 to 4 questions from lower limb, which are checking your special test. So varus stress test, it at 0 degree indicates both LCL and cruciate ACL or PCL injury. 30 degree LCL, dial test. 30 degree, what does it signify? 90 degree. External rotation recurvatum test. Positive when lower leg falls into external rotation, and recurvatum when leg is suspended by toes in supine position. These are for PLC injuries and more consistent with combined ACL and PLC. Posterolateral drawer test, reverse pivot shift. As we do anterior pivot shift, as we do pivot shift test, so there is another test, reverse pivot shift. The knee is positioned at 90 degree and externally rotated. In pivot shift, we internally rotate, apply the valgus stress, extension to flexion. And but in reverse pivot shift, the knee is positioned 90 degree and external rotational valgus force is applied to the tibia, and you will get a palpable clink on extension. Tibia reduces from a posteriorly sublux position at 20 degree of flexion to a reduced position in full extension. So it signifies the injury of the PCL as well. Now, posterolateral complex injuries, they the treatment, the surgical treatment has not been asked a number of times, but can be asked in viva. So remember three different methods of posterolateral complex operative treatment: fibular based reconstruction, also called Larson technique, transtibial double bundle reconstruction technique, and Laparde anatomical reconstruction technique. So these are three different techniques. The question is often asked, what would be the order of correction if the knee is having PLC injury, ACL injury, PCL injury? Then how will you reconstruct? So remember, first of all, reconstruct PLC. First of all, reconstruct PLC. In this question, I have not included the MCL. The MCL ACL algorithm has been discussed. Now the question is, if he has having PLC, ACL, PCL, then how will you go? Correct the PLC reconstruction, then ACL reconstruction, then PCL reconstruction. This is the order of correction. And high TBL osteotomy, I'll tell you when it is needed and how to perform it. So PLC reconstruction should be performed at the same time or prior to ACL PCL. Otherwise, there would be failure of the cruciates. Valgus high tibial osteotomy is done if there is malalignment, indicated in patients with varus mechanical malalignment. After posterolateral complex injuries in chronic cases, actually the patient develops varus mechanical malalignment. If you are suspecting malalignment in a chronic case of PLC injury, then go for the full length x-rays, apply the malalignment test, and then rule out whether there is varus mechanical malalignment or not. If it is, then you have to go for the high tibial osteotomy. Failure to correct bony alignment jeopardize ACL PLC reconstruction success. So there is a question. Let's discuss. 37-year-old male presents with continued knee pain, instability 6 months. Post combined ACL and PCL reconstruction. After a traumatic knee injury, on examination, his ACL and PCL, they are intact. However, he is noted clinically to have grade 3 PLC laxity and varus malalignment of his knee. What is the next most appropriate step? So, what this question is telling us that the patient has gone through ACL PCL reconstruction, but he has now PLC injury and LCL is also involved. So what will you do? Obtain long leg alignment films for pre-op planning, fibular based posterolateral corner reconstruction. Will you jump for the reconstruction? Will you go for the conservative treatment or something else? So this question, I think this is a wonderful question. I have given it 1 star because this question has not been tested many times. But for me, this is a wonderful question to check your concept about your understanding of the posterolateral corner injuries. So 6 months means this is a chronic injury. So you have to go for obtain long leg alignment films for pre-op planning. You have to rule out whether there is varus malalignment or no. So let me show you the varus malalignment. I think I didn't edit that x-ray. Okay, so you have to check for the varus malalignment. The question 2. 24-year-old male involved in a motorcycle accident and he sustains a right knee injury. Physical exam performed 30 degree of knee flexion is shown in figure. So 30 degree, this is dial test that has been shown, and you can see that the right side is more than 10 degree external rotated compared to the left side. Which of the following correctly describe the normal anatomical orientation of the region injured in this patient? So now the question is not straightforward. Given a clinical scenario, given a clinical test, the question is about the anatomy. Now, which structure is gone if this is the condition? This is posterolateral complex. Now, the question is popliteus inserts proximal to LCL on the femur. I have discussed in anatomy just few moments ago the relationship of LCL and popliteus on the femur. LCL is proximal and posterior. Posterior oblique ligament originates from the adductor tubercle just posterior and proximal to the medial collateral ligament. Biceps femoris inserts posterior to the LCL on the fibular head. Remember, on the fibular head, I have given you the relationship anterior to posterior. So the answer is biceps femoris inserts posterior to the LCL on the fibular head. Another question, 25-year-old male injured his left knee, motorcycle accident during examination, noted to have a positive reverse pivot shift test and a negative posterior drawer. What other examination finding this patient expected to have? Positive anterior drawer test, increased opening of the valgus. So look at the question, 25-year, age, motorcycle accident, examination, positive reverse pivot shift test, and a negative posterior drawer test. The posterior drawer test is negative. What other examination finding you are expected to have? So anything that clicks in your mind after reading the question. A 10-degree increased external tibial rotation at 30 degree of flexion. So look at the question again. Positive reverse pivot shift test, but a negative posterior drawer test. Reverse pivot shift test is positive, but the posterior drawer test is negative. So positive dial test at 30 degree would be expected in this patient with a PLC injury. The test is positive when there is greater than 10 to 15. So I have told you the difference. So must go through this explanation. Another question, which of the following best describes the anatomical relationships of lateral collateral ligament in the posterolateral corner? I think we have discussed it a lot and we will straight away go for the right answer. Inserts directly anterior to popliteofibular ligament on the fibula and courses deep to popliteus. Now, the question is checking your anatomy deeply. Inserts anterolaterally to the popliteofibular ligament on the fibula and courses superficial to the popliteus. So, in the first two options you must be knowing. This is another beautiful picture as I given you the previous one. The popliteus is deep and LCL is superficial. Another question, 34-year-old male presents with right knee swelling and symptom buckling 3 months after being involved in a motorcycle accident. He has moderate effusion, Lackman test is positive, pivot shift is positive, quads active test is negative, medial side pain with a positive McMurray test. Figure demonstrate his leg external rotation at 30 degree of flexion. However, this deformity corrects with placing knee at 90 degree of flexion. Figure B shows a standing extremity alignment. Appropriate surgical treatment include each of the following except. I'll show the figures. This is a figure. This figure is showing you something. I have drawn the mechanical axis of the limb and there is varus malalignment. As you see, the line is not passing through the center of the knee as it passes 3 to 5 millimeters medial to the center of the tibia. So there is a lot of information in this question, I accept, but this question will help you to get the correct answer if you understand the basis. Buckling for the 3 months. Moderate effusion. Lackman is positive. Pivot shift is positive. Other than this, leg external rotation at 30 degree of flexion, and the answer is PCL reconstruction. There were all the injuries: ACL, arthroscopic medial partial meniscectomy or repair, PLC reconstruction, but the PCL is intact. He has told you that quads active test is negative. It's specific for PCL. High tibial osteotomy, yes, it will be included in the surgical procedure because there is varus malalignment. So this is a wonderful question to get hold on all the ligaments which treatment have been mentioned. So must go through the explanation. Not enough time to talk to read the explanation. Now coming on to other knee ligamentous injuries. So yes, this is, I was talking with you different PLC reconstruction mechanisms. This, the upper picture, this is Larson, which is fibular based reconstruction. So there are some other treatments that I have discussed, the Laparde and anatomical reconstruction. Multiple knee ligamentous injuries we have discussed, but we must know that neurovascular injury is very important to be ruled out. Popliteal artery, peroneal nerve, these can be damaged. And proximal fibular dislocation. This question has also been not asked a number of times. So must be knowing what is the mechanism. Fall on flexed adducted knee, anterolateral is common and close. This must be remembered. Which proximal tibiofibular dislocation is common? Anterolateral. The direction is important. I just remember that it was asked in a exam. Close reduction, flexion and pressure post-operatively immobilize in extension, and if it is chronic or recurrent, then go for fibular head resection. Knee overuse injuries. Yes. Now we are going to discuss something about anterior knee pain. If you are having anterior knee pain, then how will the question in exam will be answered correctly? If it is patellar tendonitis, quadriceps tendonitis, prepatellar bursitis, housemaid's knee. Pain at inferior border, patellar tendonitis. Pain at inferior border of patella. Pain at superior border, quadriceps tendonitis. And prepatellar bursitis, housemaid's knee. So let's see a question. 22-year-old college pole vaulter has chronic anterior knee pain on her jumping knee. This is a clue. On her jumping knee. Remember, jumping is a clue and sometimes jumping is a distractor. The patient has had over 6 months of physical therapy without improvement. Initially only bothered her during training, but she is now no longer able to compete and has pain with daily activities. MRI shown. CPSP is planning to have some questions in the future with pictures, so that's why I have added it. Don't hesitate to solve the questions that includes picture. It just strengthen your skills and it does not take you away from the exam. So there are some signal changes in the patellar tendon. So what should be the treatment? The question is telling you three information. One is jumping knee. It is telling you that it can be jumper's knee. 6 months of physical therapy. It is telling you that the conservative treatment has been failed. So you will go for the surgical excision of the affected tissue. The clinical presentation, imaging, they're consistent with stage 3 patellar tendonitis. That is also called the jumper's knee. So remember and please read the whole explanation. The grading of patellar tendonitis is called Blazina staging. Another question, Bassitt Science. Sometimes some unusual signs are asked in the exam. What is Bassitt sign? Tenderness on palpation at the distal pole of the patella in full extension and no tenderness to palpation at the distal pole in full flexion. So this Bassitt sign is elicited in patellar tendonitis. Next is ITB syndrome knee. Most likely, if the question includes hill runner, then think about it and Uber test is positive, and the treatment is mostly stretching or surgical excision of the if the treatment is failed conservatively. There was a question in consecutively two previous attempts about the knee extensor mechanism injuries, and the question was about quadriceps rupture, I think. Quadriceps rupture, patellar tendon rupture, patellar fracture, and patellar dislocation. These four topics are very important, and I don't think I have seen any exam in which one question from all these patellar pathologies was not included. In quadriceps and patellar tendon rupture, aging is very important. The question, whichever in the exam, the age will guide you to the answer. Quadriceps tendon rupture more common than the patellar tendon rupture, usually more than 40 years, and males more than females, and non-dominant limb. The cause is very important. The location is at the insertion of the tendon to the patella, and the cause is mostly renal failure, diabetes, rheumatoid arthritis, steroid use, and intra-articular injection. Quadriceps tendon rupture. How the physical exam will help? There will be tenderness at the site of the rupture, palpable defect, usually within 2 centimeters of the superior pole of the patella, and unable to extend the knee against a resistance. Unable to perform the SLR after complete rupture. So coming on to few questions. 67-year-old male, as I told you, whenever the question of patellar tendon rupture, quadriceps rupture will be asked, there will be age as a clue. 67-year-old male feels a pop, has an immense immediate onset of pain, swelling after awkwardly stepping off of a curb. Preoperatively X-ray given. Suppose preoperative X-ray not given and only this treatment is given, then you must reach at the diagnosis. So preoperative radiographs is given. What will be the X-ray finding? Solvability ratio of 1.7, 1.3, MRI showing complete quadriceps tendon rupture, maintained ability to perform a straight leg raise. So look at the question. He's asking what will be the X-ray finding. So X-ray finding, the patient has undergone a tendon rupture and solvability ratio would be expected preoperatively more than 1.2. So what will be the X-ray finding? Sorry, the complete question is what will be the X-ray finding before injury? So all of the other things can be positive except the third one. So X-ray finding before his injury would be solvability ratio of more than 1.2. So go through please this explanation. It is important. The answer is solvability ratio 1.3. So these are the explanations of all the answers. Question. 24-year-old basket player feels a painful pop. Look at the age. In his knee. When landing from a rebound, he develops immediate swelling, pain, inability to extend his knee. A lateral radiograph is shown. Proper management should include which of the following? So I have the lateral radiograph is, take the lateral radiograph, same, this one. So lateral radiograph, yes. Proper management should include which of the following? Physical therapy for range of motion followed by surgical reconstruction with patellar tendon autograft. Hinge knee brace locked at 30-degree flexion for 6 weeks. Medializing, primary surgical repair, arthroscopic for debridement versus repair. This question, 24-year, painful pop, landing from a rebound, immediate swelling, pain, and inability to extend his knee. This question can also mimic that this is ACL injury, but inability to extend his knee and the radiograph, which couldn't be included but considered as of the previous question, These things will guide you that this is not ACL rupture, so primary surgical repair. While the history, so you can see the explanation, the history could be consistent with an ACL rupture. The lateral radiograph demonstrate patella alta in solve solvity ratio greater than 1.2, which in this sitting is indicative of patellar tendon rupture. Clinical findings include an inability to extend the knee against gravity. So go through this explanation. Let me come to the previous question. I think I have made a mistake in this question. The question is fine. What will be the X-ray finding? So the answer is in solve solvity ratio of the 1.3. Then solve solvity ratio will be increased. So sorry for the previous. I couldn't understand the question. Answer is given this one. The answer is 1.3. 1 is considered normal, less than 0.8 is considered patella baja. So basically this is patella alta, and the answer is right, 1.3, this one. The next question, 40-year-old recreational basket player injured his knee while jumping from a rebound. He felt a pop and developed immediate swelling. His radiograph is shown, figure A and B. What is the recommended management? So 40 years age, basket player, injured his knee while jumping, felt a pop, developed immediate swelling. Right now, I'm thinking about ACL, but then the radiographs. So radiograph, suppose the radiographs are given and we have the same radiograph as previously. So what will you do? Obtain MRI, ice rest observation, physical therapy, knee arthroscopy and repair, open surgical repair. Whenever there is patellar tendon rupture, go for the open surgical repair. The mechanism of injury, radiographs, they are consistent with a complete patellar tendon. Whenever it is, go for surgical repair. And please remember this insult solvity ratio. What is it? Patellar tendon length over patellar bone length. Normal is 1, more than 1.2 is patella alta, less than 1.8 is patella baja. With knee flexed to 30 degrees. This is very important. Question can be asked. Question, 15-year-old female cross-country runner presents 5 weeks of right knee pain, reports no constitutional symptoms, and notes the pain is worse using stairs or sitting for long periods of time. In the back seat of a car, physical exam shows that the range of motion is full and there is no effusion. Grind test is positive. What is the diagnosis? In whole question, I think when the grind test has been given and it is positive, then among the given options, the most suitable option is chondromalacia patella. Otherwise, when the question started, I was thinking many other things. You can think of housemaid's knee, you can think of uh, Sinding Larsen Johansson syndrome, the age is 15 years. But when the grind test is positive, go for chondromalacia patella. So the answer is chondromalacia patella, and this question was tested in CPSP exam. So remember few symptoms, and in physical exam, remember grind test and patellar apprehension tests. Anterior knee pains, important point. Remember, there is a condition which is called Sinding Larsen Johansson syndrome. That is the overuse injuries causing anterior knee pain at the inferior pole of the patella, at the proximal patellar tendon attachment, similar to Osgood-Scheffler's disease, which is at the distal attachment of patellar tendon. So remember, Larsen Johansson syndrome is proximal, Osgood-Scheffler disease is distal, and these are different from jumper's knee, which is patellar tendonitis. We have discussed few questions of patellar tendonitis. Recurrent patellar instability. The patellar dislocation, acute and chronic, and then the instability, all have been tested in exams. So radiographs, there are few different angles and how these are measured. You must remember, I have told you about insult salvati ratio. And now traumatic traumatic patellar dislocation, CPSP question. It was in the last 2 attempts. What was the question? There was a scenario that the patient has injury, patella was dislocated and then relocated. but X-ray shows a fragment, but it could be. So it was mechanism usually non-contact twisting injury. Patient will usually reflexively contract quadricep and reduce the patella. Osteochondral fracture occur most often as the patella relocates. So OCD, osteochondral fracture, it was the answer. It is most common after the patella relocates. So there are few things that I need to tell you. You have to memorize. This slide has been uh, detailed in the upcoming slides. You must know about the insult solvability ratio. Normal between 0.8 to 1.2. Less if less than patella baja, if more than patella alta. Blackburn Peel method, normal ratio. Catton Catton Dash uh, Champs method, normal ratio, and these three are important. You can skip the plateau patella angle. Now, insult solvability ratio, how you measure patella height, tendon height. Blackburn Peel index, how you measure it. I have given. Now, which view gives us these informations in patellar instability? Sunrise or merchant view? This was the question. Which view in the knee to comment on patellar instability? Then the sunrise or merchant view. Best to assess for lateral patellar tilt, lateral patellofemoral angle, and normal is angle that opens laterally, angle between. And now let me show you the picture. These are few angles: congruence angle, lateral patellofemoral angle, and lateral displacement of the patella. So these three are very important. Lateral patellofemoral angle, this is the lateral patellofemoral angle. What is normal? Normally more than 11 degree. Congruence angle, normal is minus 6 degree. So this is congruence angle. So normal is minus 6 degree. Congruence, lateral patellofemoral angle. Sulcus angle evaluated for trochlear dysplasia, and the value is more than 140 degree, indicates flattening of the trochlea concerning for dysplasia. Now these three angles, remember this: lateral patellofemoral, congruence, and the lateral displacement. Then coming on to CT scan, TT-TG ratio is important. TT-TG distance, if it is more than 20 mm, then it is considered abnormal. TT-TG ratio measures the distance between two perpendicular lines from the posterior cortex of the tibial tubercle and the trochlear groove. Now, about these procedures for patellar instability, what you have to memorize is what are the indications of these surgeries. There is a beautiful chart in Campbell. I would recommend that you must memorize that chart. Arthroscopic debridement or removal of loose body. MPFL repair, what is the indication? MPFL reconstruction, what is the indication? Fulkerson type osteotomy, enteromedialization, that is tibial tubercle, what is the indication? So TT-TG ratio of more than 20, I have written this one indication for this, but you have to go through the chart. Tibial tubercle distalization, lateral release, when you do it. Trochleoplasty, when you do it. Lateral release and medial plication, most commonly done, but remember the indications of all the procedures. So let's come on to the question: which of the following structure attaches between medial epicondyle and ejector tubercle of the femur? So you must be knowing, it's an easy question. MPFL, there are a number of questions on MPFL in the previous exams. So another question: 27-year-old football player sustains an acute lateral patellar dislocation. Which of the following the most likely site of injury seen on MRI? So 27-year-old, acute lateral patellar dislocation. So lateral patellar dislocation, must be knowing what are the static and dynamic stabilizer. So the answer is the third one, second one, soft tissue avulsion of MPFL. So it can be bony, but the most common as it is soft tissue, so you will go for the soft tissue of MPFL. A high school softball player, chronic activity related anterior knee pain without history of instability. Which radiograph measurement is used to indicate when a lateral retinacular release may be helpful? So as I told you, memorize the chart of Campbell. So when you will do the lateral retinacular, if the congruous angle is increased, the Q angle, sulcus angle, lateral patellofemoral angle, patellar height index. So lateral patellofemoral angle, that I told you that more than 11 is normal. So if it is not more than 11, then you release it laterally to increase it uh, up to 11 degree. So please go through the explanation as well. So this is lateral patellofemoral angle, and if you feel that the patella is too much inclined toward lateral side, then you go for the lateral release. Knee lateral patellar compression syndrome. So not many questions has been asked. I have told you about all these ratios: sulcus angle, lateral displacement, tilting, lateral patellofemoral angle, and insole salvati ratio. Knee patellofemoral syndrome. In this, you must be remembering what is miserable triad. Miserable triad syndrome is a pathology in which the patient has femoral anteversion, genu valgum, and external tibial torsion. So these are the conditions. Knee pediatric disorder, I have told you about Sinding Larsen Johansson syndrome and Osgood Schlatter disease.